Hi, my name is Joey, and I'll be presenting on the role of endoscopic imaging in photodynamic therapy and managing ulcerative colitis. Just a bit of an overview. This mini lecture is divided into three sections. First, we'll talk about what ulcerative colitis or UC is, from its origins to how it's currently being treated. Second, we'll talk about endoscopy, how it works, and how it's applied to diagnose UC. Third, we'll talk about photodynamic therapy or PDT, how it works and how it can potentially be used to treat UC. Let's go over some of the basics. Ulcerative colitis is the most common type of inflammatory bowel disease or IBD that affects the colon or large intestine, which primarily absorbs water and electrolytes from undigested food. Inflammation typically starts in the rectum and spreads throughout the rest of the colon as the disease progresses. Common symptoms include bloody diarrhea and abdominal discomfort or pain. The course of ulcerative colitis is often characterized by periods of flare-ups, where new damage occurs and patients actively experience the symptoms mentioned, and periods of remission, where the tissue starts to heal. Its occurrence is increasing globally, with a projection that approximately 470,000 Canadians will live with the disease by 2035. It is important to keep in mind that the primary goal of treatment is to achieve endoscopic and histological healing of the mucosa, meaning that the colon lining should be healed, both visibly from an endoscope and at the cellular level as viewed under the microscope. The pathophysiology of ulcerative colitis is characterized by chronic inflammation and formation of ulcers along the inner surface or lumen of the large intestine, including the colon and the rectum. This inflammatory process is typically confined to the mucosa and the superficial submucosa. The exact cause of UC is not fully understood but is believed to be multifactorial, involving a combination of genetic predisposition and environmental factors. That said, individuals with a family history of UC have a higher likelihood of developing the disease. While the precise mechanism of mucosal destruction remains unclear, some theories and correlations have been proposed. First is the gut microbiota imbalance. Patients with UC may have a higher proportion of gut bacteria that produce sulfides, and this increased sulfide production has been correlated with periods of active inflammation compared to remission. However, it is noted that this is mostly just a correlation, and the direct causal link still needs further research. Next is immune dysregulation. Certain types of immune cells, like cytotoxic T cells, are found in the lining of the colon in people with UC. The idea is that these T cells, which are normally meant to kill infected cells, start destroying the healthy cells that line up the walls of the large intestine. This destruction is what leads to the inflammation and the ulcers. And now, in terms of the spread process, there are numerous theories about how IBDs in general would spread. The outside-in theory suggests that external triggers like bacteria lead to mucosal inflammation. On the other hand, the inside-out theory proposes the disease process might start from the lymphatic system or mesentery and spread towards the gut mucosa. Ulcerative colitis is classified into three different categories. Approximately 30% of patients have proctitis or UC that is limited only to the rectum. In 40% of the patients, it is distal colitis, which extends to but not beyond the splenic flexure, just right over here. And in 30% of the patients, it involves the entire colon, or what is known as pancolitis. In terms of how ulcerative colitis is diagnosed, endoscopy, particularly colonoscopy, is the primary tool for diagnosing UC by allowing the direct visualization of the colonic mucosa. It helps assess disease extent and severity, with UC typically showing continuous inflammation from the rectum. Mucosal inflammation varies from mild granularity to severe ulcers and spontaneous bleeding. Multiple biopsies confirm the diagnosis by identifying histopathological features like crypt abscesses and epithelial abnormalities while ruling out infections or malignancies. Endoscopy is also crucial for monitoring disease progression, treatment response, and colon cancer surveillance in long-standing cases, using advanced techniques like chromoendoscopy and endomicroscopy. While radiologic imaging is not the primary diagnostic tool for UC, it is useful in specific cases. CT scans help assess complications like toxic megacolon or perforation, while MRI aids in differentiating UC from Crohn's disease by detecting narrowed or blocked areas in the intestines. Ultrasound is also emerging as a non-invasive tool to track disease progression, particularly in monitoring bowel wall thickness as a marker of inflammation. Radiological imaging can definitely help rule out other conditions that may mimic UC symptoms. Currently, there are three main classes of medications, administered orally or rectally, that are used to treat UC. Anti-inflammatory medications, which are the first line of treatment for mild to moderate UC, immunosuppressors, which work by suppressing the body's immune system, which is thought to be overactive in UC, and biologics, which are genetically engineered medications that target specific proteins involved in the inflammatory process in UC. An endoscope is a long flexible tube with a light and camera, which can either be inserted through the mouth or through the rectum. Mouth insertion allows for viewing the upper part of the digestive system, also known as upper endoscopy. On the other hand, rectum insertion allows viewing the lower part of the digestive system, also known as colonoscopy. The tip of an endoscope will include an air or water nozzle, the objective lens from the optical lens system, which allows for visualization, and light guide lens, which are the light sources that have been transmitted across the tube via total internal reflection, as well as biopsy channels, which are the opening that is used to examine tissues of the internal cavity, being viewed to and can be used to diagnose inflammatory diseases like ulcerative colitis or cancer. Image detection and processing begin with the built-in light source illuminating the internal tissue. Objective lens at the distal tip of the endoscope focuses a detailed image of the illuminated area into the CCD sensor, which consists of a grid of light-sensitive pixels. Each pixel here detects the brightness of the incoming light and converts it into an electrical charge through photoelectric effect. These charges are stored and sequentially transferred through the CCD, where they are processed and converted into a digital image. The final image is then displayed on a monitor in real time, allowing physicians to examine the internal structures with much higher clarity and precision for diagnostic and treatment purposes. Here are some photos summarizing what physicians usually see when viewing the colon in imaging and diagnosing ulcerative colitis. A normal colon will appear to have a smooth and shiny texture or surface with very visible blood vessels and light reflection. A colon with mild to moderate UC will have a rough and grainy texture with some noticeable redness, reduced or zero blood vessel visibility, and some erosions. A colon with severe UC will have severe redness due to spontaneous or continuous bleeding, visibly fragile tissue, and widespread mucosal damage. Here are some of the more advanced endoscopic techniques. Chromoendoscopy. This technique involves applying special dyes to the lining of the digestive tract to make abnormalities more visible. It is particularly useful for spotting early signs of cancer or precancerous changes in conditions like ulcerative colitis, which would help doctors identify key areas that would need closer attention or treatment. Next is confocal laser endomicroscopy. This advanced tool allows doctors to see detailed, real-time images of cells inside the digestive tract, as you can see in the photo here, which would then help them detect changes at the cellular level. However, it is really expensive, requires specialized training to use, and can only examine a small area at a time, which then limits its widespread use. Last is endocytoscopy. This method provides extremely magnified images of tissues, allowing doctors to examine cells in great detail. It is used to study inflammation and identify precancerous changes in the digestive tract, offering a closer look at tissue health rather than the standard methods. So endoscopy is a useful tool because it lets doctors see inflammation in the digestive tract directly, checks how severe and widespread a disease is, take tissue samples for testing, monitor how well treatments are working, and look for early signs of cancer. However, it is a really invasive procedure that requires cleaning out the bowel beforehand, can be uncomfortable for patients, and doesn't show how deep the disease goes through beyond the intestinal wall. It also is not perfect and can sometimes miss dysplasia or abnormal cells. Now looking at PDT or photodynamic therapy, it relies heavily on the physics of light interaction with photosensitizing chemicals. Photosensitizers absorb light at specific wavelengths, causing photoexcitation and boosting the molecules' energy levels. The subsequent transfer of energy to molecular oxygen produces reactive oxygen species, or ROS, which are superoxide and hydroxyl radicals in type 1 reactions, and a singlet oxygen in type 2 reactions. These ROS cause damage to biological components, leading to apoptosis or necrosis in target cells. So when they are administered systemically, photosensitizers selectively accumulate in target cells, and to match the absorption spectra of photosensitizers, the light wavelength and source, which are frequently lasers or LEDs or LEDs, must be carefully considered. Photodynamic therapy, or PDT, is emerging as a promising treatment for ulcerative colitis by leveraging light-activated photosensitizers to target inflammation and disease progression. Research suggests that PDT can influence multiple aspects of UC, offering potential advantages over traditional therapies. Here are three key ways in which PDT may be beneficial. First is anti-inflammatory effects. PDT helps reduce inflammation in ulcerative colitis by modifying immune responses. It lowers pro-inflammatory cytokines like IL-6 while increasing anti-inflammatory cytokines such as IL-10. PDT also influences immune cell behavior and signaling pathways like NF-kappa B, reducing colitis severity in animal models like the mice. Next is the gut microbiota, or specifically modulation of gut microbiota. PDT can restore microbial balance in the gut, which plays a key role in ulcerative colitis, as what we discussed earlier. Studies show that it improves colonic healing and regulates intestinal flora, potentially reducing harmful bacteria. These changes, though, may be a direct effect of PDT or an indirect result of reduced inflammation. And lastly, localized and minimally invasive treatment. PDT is well suited for ulcerative colitis as it can be delivered endoscopically, allowing for precise targeting of inflamed areas. This localized approach minimizes systemic toxicity, reducing the side effects. New advancements, such as shown here, which is the endoscopic capsule, can further enhance PDT's minimally invasive potential. Photodynamic therapy for ulcerative colitis has several benefits. It targets specific areas, is minimally invasive, can be combined with other treatments or repeated, and may help reduce inflammation and modulate the immune system, with early studies showing promise. However, it also has its own drawbacks, such as limited ability to reach deep into tissues, heavy reliance on oxygen, which can be scarce in damaged areas, sensitivity to light after treatment for patients, difficulties in delivering the photosensitizing agent effectively, and the deliberate need for more clinical research and standardized methods to ensure its safety and effectiveness. And that's all for this mini lecture. This slide here just summarizes some of the key information that we should have learned for today. And here are some of my references. Thank you very much for listening, and I hope you learned something.